Hello. So today we are going to discuss about multiple myeloma and related plasma cell disorders. Now in virtually all cases, multiple myeloma and related plasma cell tumor may secrete a single complete or partial immunoglobulin. Now because these immunoglobulins can be secreted in the serum, these disorders are also referred to as monoclonal gammopathies. So monoclonal gammopathies is an umbrella term in which the multiple myeloma and other related plasma cell disorders come. And the associated immunoglobulin which is secreted in excess in these monoclonal gammopathies is known as an M protein. So later on we will come to know about the gamma globulin spike in multiple myeloma, which is classically called M spike. So that's basically a protein which is associated with multiple myeloma. So this M protein is an indicative of overt malignancy, but they are also surprisingly found in a healthy elderly individuals in a condition known as monoclonal gammopathy of undetermined significance, which we will discuss later, that there is no end organ damage in MGUS as compared to multiple myeloma where there will be an end organ damage. But surprisingly normal elderly persons, you will find this M protein as well. So collectively these disorders account for approximately 15% of deaths that are caused by the tumors of white blood cells, and usually elder people are the most sufferers. So the plasma cell neoplasm can be divided into the 6 major variants. So a bit for the recall that when we were discussing the hematopoiesis, so first of all we have the multipotential hematopoietic stem cell, from which there are 2 different lineages. One lineage is of common myeloid progenitor cell, and another is of the common lymphoid progenitor cell. So common lymphoid progenitor cell can either be converted into natural killer cell, large granular lymphocytes, or small lymphocyte, which ultimately converts into either B lymphocyte or T lymphocyte. So when B lymphocyte is completely matured, so it converts into the plasma cell, which is antibody secreting cell. So plasma cell neoplasm can be divided into the 6 major variants, in which one of them is the multiple myeloma. The other is called solitary plasma cytoma. The third is called lymphoplasmacytic lymphoma or Waldenström macroglobulinemia, which we will discuss later on. And then there is heavy chain disease as well, primary amyloidosis, and monoclonal gammopathy of undetermined significance. However, we will discuss in this podcast multiple myeloma and lymphoplasmacytic lymphoma, and briefly we will just overview rest of the disorders as well. So first of all, let's briefly discuss multiple myeloma, and then we will go into the detail of the multiple myeloma as well. So multiple myeloma is one of the most common lymphoid malignancies. Approximately 20,000 new cases are diagnosed in the United States each year, and the median age of onset is 70 years in elderly population, and it is more common in males as well as in people of belonging from African American origin. So what it involves, that it principally involves the bone marrow and is usually associated with lytic lesions throughout the skeletal system. So this is the most important point which you have to understand, is that multiple myeloma, although it's a plasma cell disorder, but the most common finding is the lytic bone lesion throughout the skeletal system, not localized, but throughout the skeletal system you will find this multiple myeloma. And the most frequent M protein produced by myeloma is IgG. So again I would like to address this issue again, that the M protein is basically an immunoglobulin which is secreted in excess in these disorders, and we call that M protein. So mostly that M protein is IgG, and then IgA, IgM, IgD, and IgE is also found. And in other 15 to 20% of the cases, like majority of the cases are producing IgG, IgA, IgM, but in some of cases like 15 to 20%, the plasma cells may also produce kappa or lambda light chains only. So because of their lower molecular weight, free light chains are excreted in the urine. So when those free light chains are produced in excess, they are excreted in the urine, and where they are termed as Bence-Jones protein, and which we will discuss in detail in the coming lecture, that how this free light chains are reabsorbed in the proximal tubules, and when they will just leak into the urine, when we will call them Bence-Jones protein. So just for the sake of understanding that yes, these free light chains which are produced in the myeloma are called Bence-Jones protein in the urine, but later on we will come back to it. So even more commonly, malignant plasma cells secrete both complete immunoglobulins and free light chains, and thus produce both M proteins and Bence-Jones protein. So are you understanding the concept what M protein is all about? M protein is the immunoglobulin IgG, for example, and Bence-Jones protein is only the light chain in the immunoglobulin. Like when immunoglobulin is a structure composed of both heavy and light chains. So M protein consists of both heavy and light chains. However, Bence-Jones protein is also only having that light chains which appears in the urine. So that was just a brief introduction about the multiple myeloma, and we will discuss these all issues one by one. But before going into the detail, first of all we will just understand the concept of the solitary plasmacytoma, which is also important to understand before going into the detail of the multiple myeloma. So sometimes plasma tumors manifests as solitary plasmacytoma involving the skeleton or the soft tissues. The solitary skeletal plasmacytoma tend to occur in same locations as does multiple myeloma, and usually progress to a full-blown multiple myeloma over a period of 5 to 10 years. So it's a spectrum of disease starting from the solitary plasmacytoma to overt multiple myeloma involving the whole skeletal system. So solitary plasmacytoma is probably best thought of as the early stage multiple myeloma, and there will be the modest elevation of the M protein. And by contrast, plasmacytomas that occur in the soft tissues, most often the upper respiratory tract, spread infrequently and are often cured by the local resection. Now we will start discussing the pathogenesis and morphology of the multiple myeloma first, before going into the details of other factors. Now as far as pathogenesis is concerned, as with most other B-cell malignancies, myelomas often have chromosomal translocation involving IgH locus on chromosome 14 and various other genes including cyclin D1, fibroblast growth factor receptor 3, and cyclin D3 gene. So as we discussed in non-Hodgkin lymphomas, that there was chromosomal translocation just like in follicular lymphoma, Burkitt lymphoma, and all those non-Hodgkin lymphomas where we were discussing. So there was a chromosomal translocation. Similarly in myeloma you will also find the chromosomal translocation. So late in the course, translocations involving MYC are sometimes also observed, and as might be surmised from this list of genes, dysregulation of these cyclins is most common in multiple myeloma. So here also, just like non-Hodgkin lymphoma, you will find chromosomal translocation. Now the proliferation of the plasma of the myeloma cell is supported by cytokine interleukin 6. So interleukin cytokine is the most important, which is produced by the fibroblasts and macrophages in the bone marrow stroma. So when they will produce IL-6, so there will be the proliferation of the myeloma cells. So IL-6 is important for continuation of this disease. Now the characteristic bone resorption results from the secretion of certain cytokines, for example interleukin 1 beta, tumor necrosis factor, interleukin 6, by myeloma cells. Now these cytokines stimulate production of another cytokine called rank L or rank ligand, which stimulates the differentiation and absorption of osteoclasts. Now what it will do, that these cytokines stimulate the production of another cytokine which is known as rank L or rank ligand, which will stimulate the differentiation and absorptive capacity of osteoclasts, and then osteoclasts will start bone resorption, and hence when the bone is resorbed we will find hypercalcemia in multiple myeloma. So patients with myeloma are immunosuppressed. Through certain mechanisms, myeloma cells interfere with the function of the normal plasma cells, leading to defects in the antibody production. Thus, although the plasma usually contains increased immunoglobulins owing to the presence of an M protein, the level of functional antibodies often are profoundly depressed, leaving the patients at risk of bacterial infections. Then the renal dysfunction is a common serious problem in myeloma in almost a lot of patient population with multiple myeloma. The end result is the renal damage, and it stems from several pathological effects that may occur alone or in combination. Most important are obstructive proteinaceous casts, which often form in the distal convoluted tubules and the collecting ducts. The casts consist mostly of Bence-Jones protein along with variable amounts of complete immunoglobulins or TEM-Horsfall protein, which is found in the kidney, and albumin. So light chain deposition in the glomeruli or in the interstitium, either as amyloid or linear deposit, may also contribute to the renal dysfunction. So the assault on the kidney is completed along with all these deposition of proteins with the presence of hypercalcemia, which may lead towards dehydration and the formation of the renal stones, and then there will be the frequent bouts of bacterial pyelonephritis, which stems from hypogamma globulinemia due to dysfunctional immunoglobulins secreted by the myeloma. So hence we will have hypogamma globulinemia. So patients will be at risk of infections of the kidneys, dehydration, hypercalcemia, renal stones, as well as the deposition of the immunoglobulins. So that's why they usually presents with end-stage renal disease quite frequently. Now coming towards the morphology of the multiple myeloma. So multiple myeloma usually manifests with multifocal destructive skeletal lesions, which most commonly involve the vertebral column, ribs, skull, pelvis, femur, clavicle, and scapula. The lesions generally arise in the medullary cavity and erode calcaneus bone and progressively destroy the cortical bone. And the destructive pattern in turn often leads to pathological fractures, most frequently in the vertebral column or femur. So the bone lesion usually appears as punched out effects, maybe like 1 to 4 cm in the diameter, but in some cases diffuse skeletal demineralization is evident. So microscopic examination of the marrow reveals increased numbers of the plasma cells, which usually constitute greater than 30% of the cellularity, and myeloma cells may resemble normal plasma cells but more often show abnormal features such as prominent nuclei or abnormal cytoplasmic inclusions including immunoglobulins. So with the disease progression, plasma cells may infiltrate the spleen, liver, kidney, lungs, lymph nodes, and other soft tissue sites, and in terminal stages a leukemic picture may start emerging out. Because of leukemia picture means that splenomegaly, hepatomegaly, and features like that may appear in the later phases of the myeloma. So renal involvement, also known as myeloma nephrosis, is associated with proteinaceous cast in the distal convoluted tubule and the collecting ducts, consisting mostly of the Bence-Jones protein, just like we had discussed previously, that Bence-Jones is basically the light chains of the antibodies, light chains, only the light chains kappa or lambda. So when they are present in the urine, we will call it Bence-Jones protein. So myeloma nephrosis mostly consists of Bence-Jones protein along with variable amount of complete immunoglobulin, TEM-Horsfall protein, and albumin. Multinucleate giant cells derived from macrophages usually surround the casts. So very often the epithelial cells adjacent to the cast may become necrotic or atrophic owing to the toxic effect of the Bence-Jones protein. So there you will also find an area of necrosis or atrophy around the area in which there is deposition of those Bence-Jones protein. So other common pathological processes involving the kidneys include metastatic calcification stemming from the bone resorption, as we have discussed previously, that how the osteoclast will activate it with the help of those cytokines, and then there will be also hypercalcemia due to bone